So, Dr. GVS Murthy is currently the director of Institute of Public Health in Hyderabad. His work revolves around improving global health and fostering international partnerships to improve the health status of the population. He is been working in this area of public health for a long time. He has established the first community ophthalmology department in the public health sector in India and headed the department from its inception at the RP Center, Dr. Rajendra Prasad Center for Ophthalmic Sciences at the All India Institute of Medical Sciences. He also established the Overseas Center of Excellence in South Asian Center for Disabilities, Inclusive Development and Research in Hyderabad, and also is been on the collaborative project between this organization and the Public Health Foundation of India. So we are honored to have him here today with us. He is going to speak to us about his work in this area of community ophthalmology, prevalence and associated risk factors, and effective models to manage the magnitude of diabetic retinopathy in India. So over to Dr. GVS Murthy.
Thank you all for the opportunity to share some of my thoughts. I may be an outlier in the sense that regarding the complications like diabetic retinopathy, they may be less of an emphasis, but Professor Sahai has seen to it that when we look at diabetes, the importance of a comprehensive model of care is critical. And that is why I really appreciate this opportunity to be here. When we look at diabetic retinopathy, and we look at, say, 20, 25 years ago, it was then the 20th, one of those also had conditions in terms of the causes of blindness. And within a span of 20 years, it's moved up to be the fifth most important cause of blindness globally as well as in India. And that speaks volumes of the importance of diabetic retinopathy in terms of both the global context as well as the Indian context. Also remember that people with diabetes also have higher rates of cataract, early cataract, a higher risk of glaucoma, higher risk of myopia. So it's not just the numbers with diabetic retinopathy, but the other eye conditions to which diabetes per se predisposes are also important to keep in mind. So it's a huge number that we are dealing with. If you look at the global perspective, 2.6% of all blindness and about 1.9% of moderate to severe visual impairment, which is less than the blindness threshold but is not normal vision. And if you compare that with the situation in South Asia where we are based, we are slightly higher than the global average. And the global average translates into about 0.8 million people blind and nearly 3.7 million people who are visually impaired. If you look at those numbers and the fact that next year we overtake China, 1 out of every 4 of those people will be resident in India. And that is why looking at diabetic retinopathy and the sight loss that diabetic retinopathy leads to is important. If you look at the global data, there have been a series of meta-analyses which have been done, and the most important one, or the path-breaking one, was the one in 2010 by Yao et al., and that for the first time looked at what the global prevalence of diabetic retinopathy is. And that looked at the fact that there was about 1/3 of all people with diabetes who would have some amount of diabetic retinopathy. And looking at the 2010 data, it was estimated that 93 million were people with diabetic retinopathy. And these are studies on people with diabetes. It's not general population estimates. There have been more recent meta-analyses done, and this shows that the overall prevalence seems to have dropped from about 1/3, that is 34%, to about 1/5, that is about 22%. Good news. It means that if we do things properly, we can actually make a difference on vision threatening diabetic retinopathy as well as overall diabetic retinopathy. The bad news is this has happened mostly in the high income countries. That decrease from 34 to 22% is mostly because of the difference that we see in high income countries where screening programs have been very active and have made a big difference. So the bad news is for us in India, for those in South Asia, or other low and middle income countries, we know what has to be done, but we are not doing that at the moment. And that is the gap that needs to be bridged. If we look at what we are doing today, and if things remain constant in that manner, then by 2045, we are looking at about 160 million people with diabetic retinopathy and 44 million people who have sight threatening or vision threatening diabetic retinopathy. So, once we know the answer and we do not act towards that answer, it is, the only few people who crack JEE are the ones who are successful. The others, we should not be counted amongst them. Because we know what the answer is, we need to work towards that. And here is the opportunity that this is something which is avoidable and we could try and make a difference. When you try and look at what the situation in India is, looking at some of the estimates that we have from India, most of these have been conducted through what is called as a rapid assessment of avoidable blindness, which does not have the same finesse as a bigger survey, which is a more detailed examination of the fundus. Despite that, we get some estimates, and these estimates in India are lower than what has been projected from the meta-analyses of the global data. And we find that if you look at the prevalence of diabetic retinopathy, we are in the range of about 10 to 15%. So say we can average it to around 13 to 14%. But amongst that, if you look at sight-threatening diabetic retinopathy, it's almost 6%. So compared to what we see in the global analysis, where the proportion of diabetic retinopathy to sight-threatening diabetic retinopathy is more wider, we see that in India, that gap is less. So for almost every two people with diabetes, you're seeing, every two people with diabetic retinopathy, you're seeing one with sight-threatening diabetic retinopathy. That's not a good feeling because it's something which can be rectified. I won't go through all that data here, but just the top line findings that here, for every two people with diabetic retinopathy, we have nearly one with sight-threatening diabetic retinopathy, and that should be reversed. The risk factors, all of you are well aware of these risk factors, but I like to categorize them into four boxes. The first is biological. I'd like to change my age. I'd like to look like a 21-year-old for the rest of my life. Unfortunately, even if I look like that with Botox, my limbs will not work in the same fashion. So it doesn't make much of a difference. The genes play a role, as do the ethnicity and our sexual dimension, our male or female distribution, and the fact that pregnancy both increases the progression as well as the incidence of diabetic retinopathy. Metabolic, the two most important things that we need to keep in mind are the duration of diabetes and the glycemic control level. Lifestyle, which compounds the misery, alcohol, smoking, abdominal obesity, which is more of a predictor for diabetic retinopathy than just body mass index, and serum lipids. The other factors are again very critical. The access to healthcare, where you are residing, like you say, the postal code in the West, here we look at rural urban residents as an indicator of whether you are suffering from a higher risk. Your beliefs, your behaviors, your attitudes towards taking medications all determine the way diabetic retinopathy pans out. Systemic comorbidities is again an important thing to consider. But amongst all these risk factors, the most important that we need to look at is what are those which are modifiable. In terms of the modifiable risk factors, we were looking at access to healthcare as an important modifiable risk factor for diabetic retinopathy. You club that with a biological factor like gender, and then we realize why access to health services, access and affordability to diabetic care is so critical, because women are the one who stay back, do not come forward for treatment, and therefore do not have a voice in their management of diabetic retinopathy. And that is why we see this gender disparity, which increases with age. As you get older, this disparity continues and also increases. So that is something that we can make a difference and should make a difference. We did this survey in 11 cities, where Professor Rakesh Sahai was also part of this study, to look at what the client perceptions are in terms of complications of diabetes. And if you look at this particular slide, 41% of people with diabetes who were interviewed ranked vision loss as their most dreaded complication. All the other complications are also important, but they were worried that if they would go blind or visually impaired and live the rest of their life, it would be a misery for them. And therefore, vision is so critical when we're looking at diabetes. What were the barriers that people talked about? 50% of people with diabetes do not know that they have diabetes. The complications occur over a long period of time, a prolonged period of time. And therefore, the perceived seriousness, kal dekha jayega, that sort of an attitude sets in, and it's there for all of us. The cost of care, modifiable and something that we can act upon. The need to visit different locations. For eyes, I have to go to one place. For my kidney functions, I have to go to another place. For my diabetic care, to another place. For my neuropathy, to another place. So people felt it is very difficult to go to different places for one condition, and therefore that becomes a barrier. The tediousness and lethargy of lifelong medication. You ultimately get bored. If you like biryani, but every day if you have to biryani, ultimately you get bored after some time. It's worse with medications because there is nothing palatable about medications. The other thing that we have to remember is that if there is one person with diabetes in the family, it is difficult to cook for that one person exclusively. So the whole family's attitude has to change, that diabetic diets or diabetic causing diets have to be looked at for the entire family rather than for one individual within the family. From the provider side, there's so many people who are providing instant magical cure practitioners at the local level. And that is a barrier because allopathic medication is not something which is a magic bullet. It can reduce the situation, but will have to be continued for a long time. The lack of communications between the ophthalmologist on one side, the diabetologist on the other side. With the same person, we do not even share notes, and that I think is a big barrier in the system. The paucity of a comprehensive diabetic care setup, and because Sir is here, I think this is a great opportunity that at least a couple of comprehensive diabetic care centers could be set up in the state of Telangana to become a model for the rest of the country. That is the request we would have, where everything is done under one roof and a person with diabetes does not have to go to 5 or 6 different locations. एक ही जगह treatment हो जाए सारा, the patient will comply better compared to going to 5 or 6 places. Uh, Involving the community, task shifting.
So Murthy, can you just elaborate why the 4-5? What are those things?
So, sir, किसी को आँख दिखा diabetes में complications like eye complications are there, kidney की complications होती हैं, nerve complications होती हैं. तो ऑफ्थल्मोलॉजिस्ट आंखों को देखता है तो ही हैज़ टू गो टू एन ऑफ्थल्मोलॉजिस्ट अलग जगह, डायबिटोलॉजिस्ट एक जगह बैठते हैं। तो इन सब के लिए एक कंबाइंड सेंटर, जैसे गोवा में मेडिकल कॉलेज ने एक शुरू किया था सर, जहाँ पे उन्होंने सारे के सारे एक ही रूम में सारे सर्विसेज प्रोवाइड करे थे, तो उससे जो है बहुत फर्क पड़ेगा सर। The other thing is about task sharing. हर चीज does not have to be done by the ophthalmologist. If we have good trained nurses, images अच्छी तरह ले जा सकते हैं, and they can then immediately tell the ophthalmologist कि इस particular person को immediate care की ज़रूरत है. Just looking at the ophthalmologist doing everything is a waste of resource, क्योंकि बहुत और काम है. Cataract has to be done. You have to look at glaucoma. You have to look at refractive errors. So trying to look at task sharing, where people with some skills can be trained to pick up people with retinopathy, that will be an excellent way to go forward. अलग अलग स्क्रीनिंग मोडालिटीज़ हैं, इसके ऊपर मैं अभी चर्चा नहीं करूँगा. Just to say that there are cameras that are now available, और जहाँ पे you can get a very good image, और अगर आप dilate करके देखते हैं then you get a much better image. And nowadays we have ultra wide field fundus camera, where even without putting dilation you can still get a very good view. They are costly, but again, a couple of centers like Osmania Medical College can actually, and Sarojini Devi Eye Hospital, can actually look at something going in that direction. बहुत से screening modalities हैं. It could be either in hospitals or in the community, and people have experimented with these facilities in India very successfully. And we can learn from some of these successful stories. We did this Queen's Trust Diabetic Retinopathy project across 10 states in India, where Dr. Rakesh Sahai was also part of that, and we showed that you can work very successfully and make a difference if you have a primary care approach, which is where diabetic retinopathy, हमारे जितने primary health centers हैं, community health centers हैं, and district hospitals can become the basis for diabetic retinopathy screening. अलग अलग किस्म के लोगों ने trials करे हैं, very successful, and we'll be very happy to share these models with you, sir. Just before I end, I will talk about artificial intelligence. आजकल हम जहाँ पे भी जाते हैं, पहली चर्चा यही होती है कि आर्टिफिशियल इंटेलिजेंस से हमने क्या किया. But artificial intelligence is not the only answer. And this is recently a study done in the US, जहाँ पे उन्होंने 7 different artificial intelligence के algorithms test करें to see how good they are. When we are looking at artificial intelligence, or in fact any diagnostic test, 90%, 90% sensitivity or 90% specificity. हालांकि that is when you detect somebody, how many of them are positive? अगर मैं 10 लोगों को देखता हूँ, 9 of them must be truly positive. That is sensitivity. Unfortunately, the 7 images out of the 7 systems, only 2 had sensitivity better than a clinician. So the artificial intelligence models that are available at the moment need to be improved upon to see that they are better than the human diagnosis. We have a shortage of human resources. So how does artificial intelligence help? By supplementing the human resource. अगर आपके पास sensitive artificial intelligence system है, then it actually acts as a positive spin for the care of people. So what we now need to do to tap the potential, task sharing, not the ophthalmologists, not the physicians, लेकिन हमारे optometrists जो हैं, ophthalmic assistants जो हैं, nurses जो हैं, they can be trained to take images, and that will reduce the burden on the ophthalmologist. And that अगर हम artificial intelligence को इस तरह improve करें ताकि उसकी जो detection rate है goes up beyond 90%, cost reduce करेंगे, एक्सेस improve करेंगे और reach improve करेंगे, which is the goal for fighting diabetic retinopathy. Thank you very much, sir. It's an honor to speak in front of you.